Good evening, everyone, and welcome to our Aged Care Billing and Japaci Essentials webinar. When I refer to Japaci, I'm talking about the General Practice in Aged Care Incentive, which sits under My Medicare. Tonight, we'll be focusing on GP billing in residential aged care and how billing activity aligns with Japaci requirements. We'll also see a live demonstration of Puffin, our polar-based tool developed to support Japaci by helping practices track visits to aged care residents, monitor vaccination status, and streamline reporting. My name's Deb Peluso, Project Lead GP Matching at Western Victoria PHN, and I'll be your facilitator this evening. Alongside me is Jade Buller from the Workforce Development Team here at Westvic PHN. Before we kick off, I'd like to acknowledge the Wadawurrung land that I'm living on and pay my respects to the elders, both past and present. We at Western Victoria PHN support self-determination for First Nations peoples and organisations. I'll give you a moment to check out some of our upcoming events you can see on the screen. A link will be shared in the chat where you can browse the full list and register. You can also access most of our previous webinar recordings for free on our PHN Learn YouTube channel. The link to this will be available in the chat as well. On this channel, we recently uploaded a video in February on the Victorian Virtual ED and the Virtual Specialist Clinics. It's a really informative overview, so I'd encourage you to take a look. Also, please get in touch with us if you would like information sessions on any other topics. Our Learn and Network newsletter is the best way to stay up to date with our latest education opportunities and upcoming events. If you haven't received an edition yet, please subscribe via the link in the chat or scan the QR code now on the screen. Just give you a moment to get your phones out. Newsletters are released on the first Tuesday of each month. And a reminder about Health Pathways. It's a free online resource with local clinical and referral information for health practitioners. Could I ask that you all please ensure your full name is displayed here in Zoom correctly for your certificate of attendance, updated or added in the chat if needed. This session is being recorded, so please stay on mute during the presentations and use the chat for questions. We'll cover these in the Q&A at the end, where you're also welcome to ask verbally. And your feedback is important to us, so please take the time to complete the event survey after the webinar. There'll be a link in the chat box to complete the survey. And I'll just take a couple of minutes to touch briefly on Japaci and the work we're doing at the PHN to support you. As you know, Japaci sits within My Medicare, and one of its core aims is to strengthen continuity of care for residents in aged care. It formalises what already many know and what you're already doing, and that is providing that regular proactive care to a complex and often vulnerable patient group. At Westvic PHN, Kelly Sullivan and I are working closely with practices and aged care homes across the region to understand what this looks like in reality. And that includes who's visiting which facilities, what's working well, and where the challenges are. So that could be about coordination with facilities, addressing administrative burden, or navigating eligibility and claiming requirements. A big part of our role is to make this easier. So that includes connecting GPs with local aged care homes through our GP Aged Care Match service, or supporting you to build those relationships if you're looking to get involved or to expand work in this space. We also provide practical support around Japaci, helping you make sense of the requirements and how that fits into everyday practice without adding another layer of complexity on top of your day-to-day work. One of the tools we've developed locally to support this is Puffin. And Puffin is designed to help practices keep track of aged care visits and appointments and better understand activity over time. It can support you in monitoring service delivery aligned with Japaci requirements and just give you that clearer visibility of your patient cohort in aged care. So Sarah Crowe, manager of our digital health team, is here with us this evening and will show you a quick demo of that after the first presentation. I also just want to acknowledge something up front. We know that many of you are involved in aged care because you value that continuity of care and want to keep supporting your patients when they move into aged care, or because it's an area of clinical interest. And we recognise that this work is complex. It takes time, coordination, and it involves additional effort that isn't always reflected in a standard consultation model. So government incentives, past and present, including Japaci, have been introduced to better recognise that complexity and ensure there's more appropriate compensation for the work being done. But having that incentive in place is only a part of the picture. It really comes down to how this translates into daily practice and how you structure your visits, how you bill, how you make this work sustainable. So to build on that, we've invited Dr. Ashley van Leeuwestyn from Better Billing, who will take you through practical approaches to billing in aged care, how to navigate the MBS, optimise claiming, and ultimately make this work more financially viable in your practice. So I'll hand over to Ash now. Thank you.
Thanks, Deb. No problem. So look, I'm just going to share my screen really quickly and get started on this one. Okay, so RACFs and Japaci, is it worth it? So for those of you who haven't met me before, my name is Ash, and I am a GP. So I am a GP in New South Wales based in Lake Macquarie, which is kind of between the Central Coast, between Sydney and Newcastle, and you put a dot in the middle, and that's where I practice. I'm also the owner of Better Billing, which is a Medicare billing education program and consultancy business, which also provides presentations, which I've done quite a few for this PHN, which has been great. In terms of my background, as I jumped on the Chat GPT bandwagon like everyone else and said, tell me what my life is like. And it was pretty spot on. So holding onto the little toddler girl who keeps me very busy. We live by the beach and I'm endlessly trying to find something new to create, especially in terms of resources for better billing. So hopefully you'll be able to get some of those along the way. But all of the resources that I talk about tonight are found on my website for free under free resources tab. So this is just a little bit about better billing as well. So like I mentioned, we do subscriptions, so which are courses that I've built myself, mostly around Medicare and teaching you about different types of Medicare billing, lots of different workflows and how it can work in your practice. We do have a lot of templates online as well, available on our website, webinars like I've mentioned, and also some practice support consulting for individual practices who might want to take their Medicare billing just that little bit further. So let's talk about RACF work. Now, I am a GP who also works in RACF around my local area, and I have ever since I've been a registrar. And even though a lot of people tell me you got to give it up, like just let it go, I can't. And I really do like it for a few different reasons. For me, I really like the MDT environment for just not sitting in the chair and doing something that's not sitting in the chair, which for me is traditional general practice where I see people in my room and I have appointments with them. I find it's very, very high value clinical work. So you will see a lot of things in patients because they are predominantly quite elderly, quite end stage, and it really shows you a lot of different pathology that you might not have seen in your normal cohort of patients. It's very predictable for me. So I'm always there in the same times every fortnight. I have the same telehealth phone calls every fortnight. I know exactly when what I'm doing when I'm doing it for my RACF. I also have, which we'll find soon, a lot of really clear recurrent like sort of recurrent billing practices that are happening as well for my chronic disease item numbers, etc. So we'll have a look at those. Also, I find this is actually quite financially viable if you structure this properly. And so hopefully tonight I'll be able to show you how that is. And if you work in an RACF or you have a colleague who works in an RACF and you just wondered, are they able to, is there something that I want to do to elevate it, then please send them this link of after we've recorded this anyway and see how it goes. So RACF billing. So to start with, I'm just going to start with your general times, and this is just general attendance. So this is an excerpt of my MBS cheat sheet, which is available online right now. And you can see these are the little color codes, and these are based off time. And this is important because for a lot of us, I personally go to my RACF at 7 a.m. Because it's the time of the day that I can get there, and that's what I do. Some people, they might do it at 7 o'clock, they might in the evening, they might go on the weekends, they might do in the middle of the day, whatever works for them is absolutely fine. But here, take note of the color codes for me. So you can see here, we've got the item numbers in the middle, which is the RACF item numbers, and they're in relation to your general like item numbers. So you can see here you've got your 3 and your 23, the correspondence of it. Then if you are doing out of non-urgent after hours work, say for instance going early or going later in the day, then those codes look a little bit different. And then of course talking about your flag for, so the 9001 as well. Urgent after hours or urgent unsociable hours are also found below, which can be used for any of the three areas. But for that, in terms of general attendance, I'm not going to cover too much because most of us already know about it. However, the item numbers are here for you to be able to access on my website. So let's talk about the item numbers that we should be talking and doing and completing for each of our residents at the RACFs. So the care plan contribution, or the 731. So 731 is $82.10, and this can be done every 3 months. You can bill these earlier if there is serious clinical change. Personally, I don't, unless there was a new resident that I've taken over and there was completely different goals of care. However, in this case, I generally find I don't really have the time. And so for me, I often will have them done every 3 months. Now, 731s are not something that you can just bill without doing any actual action. So it's a GP contribution to an RACF developed care plan. So we've all probably seen them at our RACF. If you're not sure, you can ask the care managers there. They're generally generated by RNs. And it's not like your own plan, like a care plan. So creating your own care plan is not technically what you should be doing in these cases. You're contributing to a care plan that already exists. So quite often, I will do these with new residents that I take on if there's clinical change, but I also make these routine structured reviews. I quite like them, and the way that I tend to set them up is getting them done around the same time that I talk about case conferencing. Now, I'll talk to you a little bit about that and what that looks like, but it's a really good way to be able to get the details and the goals from other allied health or the care managers involved, and including that as your contribution. So it doesn't really require that much effort because you know about the recent goals created from the case conferencing. In terms of the requirement, the patient has to be an RACF patient and they need to have had a chronic condition for more than 6 months. Now, that is that I don't think I've ever had a patient in an RACF who does not have a chronic condition. They need to continue to have their providers involved in their care, and that will be very easily fit within the RACF model. And you need to document it. Now, a good thing to note here is you cannot bill this with a 739, which is a case conference number. These two can't happen at the same time. So only one can happen within the one attendance and another one can be done on another day. Because quite a lot you will see there's overlap, but that's not the purpose of this item number. The purpose of this is to contribute to a care plan that already exists. So this is the note that I tend to use in my notes. This is available on our site. You're absolutely welcome to take this. Otherwise, is the note that I put in my software to say that I have completed a 731. So in this particular case, I see a patient who, say, for instance, has dementia, type 2 diabetes. They've also got recurrent falls. And I will have a look at what I do here is the clinical review component. So I look at their meds, having a look at their meds. Are there any changes? Do I need to delete the PRN that's been sitting there for, 6 weeks and it's not being used? Their functional status, has things now dropped? Is their ADLs now worse? Are their falls risks now out of control? What's the situation? Cognition, is it stable? Is it getting worse? Is there a delirium happening? Has there been any recent events? Particularly in this case, have they been to hospital or not in the last 3 months? Then my contribution is often about talking about any changes that I've made. So is there changes in medication? Has there been changes in my recommendation of maybe just continuing with their great care of falls prevention? Has there been maybe the consideration of adding in the physio again or wanting them to see podiatry? Whatever that might be, that is my contribution, is my recommendation. Now, moving on to another item number is 707. Now, this is a time tier based health assessment, and all of my 707s in the RACF are done by a health assessment done by one of our practice nurses who goes out, which is extremely valuable. And I totally understand if you don't have access to that yourself. However, it is quite worth, doing these annually for what we call the CMA, which is your comprehensive medical assessment. Now, these at a 707, which is more than 60 minutes has been spent with the patient between the nurse and yourself, is $313.60. So it's a decent billing. Now, in terms of this can be done on admission. For a patient, as long as it's not been done in 12 months by another RACF GP, and then you can do it annually. So for me, I get these ones done annually. They're on recall for me, and my nurse will go out quite often, annually to repeat the same CMAs. Now, we do have a CMA template that's available online and for free on the right-hand side. You're very welcome to upload that into your software, namely BP or Medical Director, whatever you're using. And you're very welcome to use this as a template. This template has been created purely based off the requirements from the MBS. So this is what Medicare requires you to complete in a CMA for an RACF patient to fit the Medicare's actual criteria of a CMA. However, a lot of us have our own versions. However you prefer to do it is fine, but having a look at the template on the right-hand side will explain to you what the minimum requirements are in that actual health assessment. One of my favorite item numbers is the RACF medication review or a 903. These are so helpful. And if you have a pharmacist that's going out to the nursing home already, this is excellent. Otherwise, speak to your local pharmacist, find out who's doing home medication reviews or residential medication reviews, and get their number. Really just bug them with people that you want them to see. There is so many medication interactions that we're missing or that we might not have been able to know about, and our pharmacists are a great tool of helping us pick it up. So I often will have my pharmacist involved in so many things, particularly the medication reviews and the MDTs or the case conferencing. But this item number can be done annually. So it's every 12 months. The pharmacist will attend to the RACF. They'll quite often talk to your facility managers and talk to the patients about their medications and have a look and review. But the GP's role at this stage essentially to obtain consent and seeing the patient. So you do need to see the patient when you deliver the outcomes of the 903. So you're providing the pharmacist with any sort of clinical information and then also reviewing the pharmacist report. It does require your feedback as well and talking back to the pharmacist, whether that's through the documentation or talking to them on site about updating medication plans and implementation changes. So a lot of your excellent pharmacists work out there, and they often will have these lovely little tables, and it will give you a written section of what you would like to do with this information. And it might be as simple as, thanks for letting me know I might monitor this, or that's a really good idea, I'm going to stop XYZ, or I'm going to start XYZ. And so I really do recommend that if you're not already doing this for your RACF patients, it's really easy, it's really simple to do. It's a great billing number as well, but it's also very beneficial for your patients. MDT case conferencing, one of my favorite things actually at the moment because a lot of people don't do it. And MDT case conferencing is so easy to set up in the RACF space. So an MDT is multidisciplinary team case conferencing, and case conferencing can happen once every 3 months. Now, patients who can have these case conferences are those who have chronic complex conditions, so such as those at the nursing home, and they need to have the GP organising this case conference and at least two other health professionals. Now, for me, it's quite often the nursing staff or the nurse care manager. My own practice nurse will often be involved, the pharmacist, and we do have an intermittent visiting nurse practitioner who I will also get involved in the case conferencing. So all the participants have to be involved in the patient care in some way. So that might be that they are the care manager, their pharmacist that's seen them last month, my nurse who came with me to do their vaccinations, whatever that might be. So there is minimum attendance requirement. So it's not, there has to be the two other providers there to fit that criteria. So it can't just be you and the care manager. It needs to be set set up in a way that you are conferencing. Now, this can be done face to face, on phone, on video. I like to do them over Zoom purely because I'm doing them in my office. And then based off the time, you bill a certain item number. So 735 is anywhere between that sort of 15 to 20 minute ratio. The 739 is the 20 minutes plus, and the 743 is the 40-minute plus. So the time, which is the actual meeting, the discussion of the case, not preparation, is the item number that you bill. Documentation is very, very important when it comes to case conferencing. And for me, I'm a big lover of AI and I use it quite readily. And so as a result, I have a documentation template that is input into BP for me, which has the date, the duration of the conference, how long I'm talking for, the names and all of the participants in the case conference and what their roles are, the clinical issues that we discuss. So particularly there might be new falls risk, there might be worsening dementia, etc., and what an agreed management plan is amongst all of us if there's any need for a change in management. And at the bottom of the MDT, there is the requirement of needing to see the outcomes and what responsibilities we assign. So say, for instance, it might be my responsibility to follow up some blood work. It might be the nursing care manager's responsibility to check on how falls risk management's happening inside of their room, whatever that might be. And that is quite easily able to be obtained in AI software. Otherwise, alternatively, you're very welcome to have a look online. And I do have a template if you're more of an actual writer or prefer to type. That's absolutely fine. In terms of compliance, so really common pitfalls is people forget they need to have the 3 providers. They realize that they can't bill for just the planning or the referrals. It actually is the conference time. Each provider has to also actively contribute. So they can't just sit there and not actually contribute. So for me, I always go around at the end and ask any comments, anything else, anything that you noted, just so that we're really making sure that everybody's contributing. And it also needs to be clinically relevant. So is there actually something here for this patient? So no, not always am I doing all of my patients need a 739 or a 735 case conference, because there might be absolutely no changes and I might not have needed to do anything. There is no annual cap with this. Okay, so it needs to be clinically justified, but for me, I'm doing them every 3 months, which is very clear in the way that I like to do my cycles for my RACF patients. A little mention about some new patient end support items. This is about looking at where the GP is actually in the same room for the patient during a video consultation with a non-GP specialist or consultant physician. And you can see here, this is about supporting your patients, particularly either in your rooms, outside, or in the RACF. And so these are some item numbers I wanted to mention about before. There is the NP and the PMP equivalents as well for those numbers, but in this case, these are the GP numbers. And that's about that. It doesn't actually require you to be consulting. It's mostly for you to be there supporting the patient, providing any feedback or having any sort of discussion with the consultant if needed be. But I did want to mention about these because they are quite common, becoming a little bit more common in the RACF scene. So then I love to talk about this item number 10997, which is the nurse-initiated care item number. If anyone's ever done any of my talks, they absolutely know that I'm going to bring this up. The nurse-initiated item numbers in this particular case that I'm going to talk about is the 10997 one here. And these are the common nurse-initiated items that I often talk about. So for these patients, these are where you can bill a nurse care, follow-up care after a care plan or a 731 has been created. And it can be billed 5 times per year. And it's based off the activities that your nursing staff have done for that patient. Now, a lot of people say to me, Ash, what on earth is my nurse in practice going to do in a nursing home for me? And there's a lot. So for me, it's about immunization. This is when I normally get my nursing staff involved, is being able to help me with the annual influenza vaccination if I have COVID boosters that are due, pneumonia needles, shingles or Shingrix, the new RSV being covered for anyone over 75 from the middle of this month. That will be another 10997 opportunity for me. I do have a particular wound care nurse who I love to get them to come in and have a look or look over telehealth on wounds for me just because of their expertise. Otherwise, if there might be other vital signs or chronic disease management monitoring that I'd like them to do when they come for a 10997 visit, then that's absolutely fine. And I have also had them involved in helping with advanced care planning too. However, I do say predominantly for me, I organise all of my vaccinations of my nursing home patients, and so that's where they often will help me. Let's talk about GPACI. So general practice and aged care incentive. So GPACI, what it is, I love the idea of Puffin. I can't actually wait to see it. So for me, it is simple and complex because all of a sudden we were getting these incentive payments and then they were kind of gone, and then now there's a lot more rules around accessing it, but it seems fair. So what is it? So it's really started from in July 2024, replaced the PIP. And it's where the government is paying us incentives and our practices incentives to be able to provide ongoing RACF care. It is now tied with My Medicare registration. So we're starting to find more of our billing item numbers are being tied with that My Medicare registration. So who can have GPACI? The patient is a permanent RACF patient. They're registered with you in My Medicare, and your practice is registered for My Medicare and GPACI as well. The GP, the personal GP that is providing the care, needs to be linked through My Medicare through that practice as well for this to all work. So that it does seem like a little bit of a mess because you've got almost like a triangle, but having sure that you've got your practice is registered for GPACI and My Medicare, and your GP is also registered in the requirements in PRODA is really important, especially for getting those payments regularly. So what do you actually need to do each quarter for the 90-day cycle? I'm not going to spend too much time on it because I think it sounds like Puffin's going to do this entire job for us, which sounds exciting. But the responsible GP and practices need to fit this servicing requirement to be eligible for payments. So there needs to be 2 care planning services over the 12 months. So that's your 731s. You need to get those 731s done. Then you've got 2 regular visits per quarter in each separate calendar month, delivering an actual attendance item to those patients over a whole 12-month period. Quarterly visits, so at least one of the regular visits have to be provided by the GP. The second visit, however, can also be provided by another GP in the practice, or say, for instance, a GP registrar, or a nurse practitioner that's linked with your practice, or an Aboriginal and Torres Strait Islander healthcare worker is also able to do that. For those who are in MM4 and MM7, so those modified Monash areas or those particularly rural areas, practices will actually be able to provide 4 regular visits of eligible telehealth items in that 12-month period if for some reason they're just not able to access the care face to face. And there are some of those really rural areas that do have those telehealth services happening. So in terms of the payments and the money, in terms of what comes in, it comes in quarterly payments, but you get paid $300 annually per patient that you're seeing. Your practice will be paid $130. That is the last time I checked the on HealthGov, but I understand it's still the same. I checked my own GPACI payments the other day. It still looks exactly the same. You can check your own GPACI payments, and what's come through is actually through PRODA, through your own payments, and you can see exactly which patient is related to each payment. Is it worth it? So, in terms of this is a bit of a model that I've been able to do when everyone sort of does their maths once and they sort of say, okay, is it really worth me spending this time with the RACF? And, financially, is this a good idea or not? So I've done this a little bit of an estimate based off 40 patients. This is say if you took care of 40 patients. All of them are approximate, so please don't hold me to absolute dollars and cents, but it is generally correct. So the setup here that I've said is there's 40 RACF patients on the GP's books. All of them are My Medicare registered, which is excellent. Thank you everybody for organising that. 25 of them you probably would see each week. So whether that is a telehealth attendance or a face-to-face, obviously you do need to do a certain number of general face-to-face attendances. But in these cases, say you're seeing 25 a week. You've got your annual items, which is your 903, which is your medication reviews, your 707, which is your health assessment. Then you've got your quarterly items. So you've got your 731, which is your RACF care plan contribution. You've got 10997 because you're taking your practice nurse out there once every quarter. You've got a 735 case conference, and you've got your GPACI incentive as well. And then for those in the weekly items, the general attendance here that I've used is a level B, so 90035, plus your bulk bill incentive that you will generate from seeing a patient, bulk billing them in the RACF. So if I have a look at the annual item numbers here, you can see here the calculations that I've got. So we've got here the a 903, so you're doing them once per year, and then you've got them at $123.70, you've got 40 patients. Then you can see you've got the 707 here, which you've got 40 patients doing that each year. Then you've got the Japaci payments, which is 300 each of a total year. So you can see here we've got about 29,492 in annual items. Then we've got our quarterly items, so a 731, a 10997, and a 735. So you see here that's adding up to about 39,000 so far. And we've not even done general attendances yet. And then if we add in our general attendances of if we've seen the patient, 25 patients per week. So if we have a look at this in terms of our annual revenue, ignore that number, my apologies, it's going to be looking at about 146,000. So if we put that through our table here, and I try to think about it, so yes, you go in and you see the patients for say 2 hours or 2 to 3 hours, then you think about the work that you have to do afterwards. They'll often come back and sort of say, oh, we need this charted, there's this happening. I have an urgent review. One of the patients has become palliative, whatever that might be. I worked it out to be roughly that the effective hourly rate for the work that you do with the nursing home is about 626 hourly in terms of how much your billing is generating by seeing patients under the RACF. So for a lot of us, that actually is not a bad option in the long term in terms of financially what we're sort of generating in hourly in practice. It might be more, it might be less, but for me, I feel like it's actually a decent financial choice at the moment, and which is why I've not given it away, but also my enjoyment of it as well. So if there is any questions, I believe we're leaving them at the end until after the demonstration. And then otherwise, you're very welcome to add them into the chat. If anybody has any other questions, there is a QR code that's here. This will take you to my website, which will be able to give you all the resources that I've talked about tonight. But if you have any other questions, otherwise, please start to type them. But I will hand it over to Sarah. I'll stop sharing.
Thanks, Ash. What a great presentation. I learned so much coming from a different angle of understanding Japaci. Hi, everyone. I am Sarah Crowe. I'm the Digital Health Manager at Western Vic PHN. And that means that me and my team, we go and visit mainly general practices, but sometimes some other primary care professionals to help you use existing digital tools in a meaningful way that actually impacts the way that you work. So we're all about the meaningful use of digital health tools. Prior to working in this space, I was a practice manager myself in general practices and allied health. But I'm also, I think it's relevant for this session to call out that I am the daughter of a very passionate, now retired GP who was very passionate about aged care and looking after his community. So I always say I was born and raised in a general practice. So when these new requirements came out for this new incentive program, I think it was in mid to late 2024 was when that happened. We had a look at those requirements, and as a team sat down and went, well, this is pretty complex. Everything Ash just showed you around, we need 2 visits per quarter, but one must be provided by the assigned provider, and they have to be in separate calendar months. And there's all these requirements you have to keep track of. And in my head, I imagined my dad going back through billing history on a patient file and thinking, oh, there's no way he would ever have done that. So is there a better way? Is there an easier way we can help everyone partake in GPACI still, but make it a bit easier to track and manage? So we contacted Polar. Some of you might be aware of a program called Polar. That is provided to all general practices in Western Victoria. You can have access to it for free. I think we have about 85% of practices in Western Victoria already have it. We provide the training, we provide the support. So we contacted that software company and said, hey, if we helped you come up with how this is going to work, do you think it's possible that we build a tool in this platform that GPs already have access to? And they said yes. So we got to, I think it took about 6 to 8 months that we got to build this tool together. And now all of Polar's products are named after an Arctic animal. So before I show you, I would like to tell you that we did get to name the tool and decide what Arctic animal it was going to be. And we decided to go with the Puffin, which are beautiful Arctic birds. They're known to be intelligent tool users. They travel extensively and they form long-term relationships. So we thought that suited, also they're just super cute. So we thought that was an appropriate way to go about it. And without further ado, I'm actually going to show you what it looks like. It's now been rolled out across Australia. So anyone that already has access to Polar has also got free access to Puffin. I'm just going to share my screen and just checking that's come through. Everyone can see my Polar screen. So this is what it looks like when you log into Polar. Some of you will have done this before, some of you might not have. But you can see we've got a big Puffin sitting there on the splash screen anyway. So I would like to show you exactly how it works. So you're going to see a bit of an exciting little dashboard that everybody has access to. All right, so here we go. Given everything we've just heard from Ash about what the requirements are, I want you to have a look. This is a fake clinic. These are all fictional patients and fictional doctors. You might see some funny names in there. Please enjoy. On the very left-hand side, I've got my list of doctors. And then next to that, I've got all my fake patients, all my patient names, their age. Now, across the very top, you've got those payment quarters that Ash was talking about. And if I hover over it, you can see when that quarter starts. But as you can imagine, each patient has their own 12-month cycle because it depends when they were registered for GPACI and My Medicare. But you can see that represented by the dark blue bars. So if I take Alexis Ford, this top patient here, their assigned doctor is Desmond Tutu. And you can see that they first registered for GPACI last quarter 3. And you can see that there. Now you might notice a whole lot of little dots happening in this current quarter that's highlighted. So what you're aiming for, as Ash said, you want 2 regular visits to your patient. So you're aiming for 2 dots. And the beauty of using a digital tool for this is it's already checking who provided the service, was it in a separate calendar month, and is it one of the eligible item numbers that counts as one of those visits. So you're not constantly going back and checking this long list of what item numbers you're allowed to use and whether it's part of it. This is going to do all of that for you. So it's pulling the information from the billing history in your best practice or your medical director or your ZMed. And it's already telling you that this second patient, Annalise, they've had both of their visit requirements this year. That's all fulfilled. And this patient's also had both of their care planning items for their 12-month cycle. So this little icon is for care plans, and this little icon is for those quarterly visits. And as you can see, as I hover over them, it's giving me a bit more details about this quarter. If I go ahead and click it, it'll give me details about that patient's year. So you can see all the details as to whether it was provided by the assigned provider, what the item number was, what date it happened, and what patient quarter it was. So it's checking all of that for you. And you can see this is a big fake clinic where I've got lots and lots of doctors and lots of patients. So you can really easily see at a quick glance what you still need to do this quarter. I'll see if I can find an example where it's showing that if the items were provided by somebody else or in the same calendar, it may not count. I can't find one. That's okay. This is all test data anyway. You might notice a few extra things. We've included some vaccine eligibility. So if you see that COVID and flu come up, that means according to your best practice file, so it's not checking air, according to the best practice file, they're eligible for a COVID shot and they're eligible for a flu shot. Now there's lots of filters I can put on to help me manage this tool. This is the whole clinic, but I could, if I just wanted to look at my own patients or one doctor's patients, I could put that little filter on that goes up the top, and you'll see that now I'm just looking at Dr. Doogie House's patients. I can always get rid of that. The other thing you can do is we've entered a few quick filters. So if you wanted to know, well, okay, I just want to see the patients who still need a visit this quarter, you can tick that filter, give it a tick, it goes up the top, and it's just showing me patients that need another visit this quarter. All right. So we've had some practice managers very excited about using this and stopping to use their spreadsheets that they've either got from the department or they've built themselves. I've been in a lot of clinics where they've built a complicated spreadsheet themselves and someone's going in and manually adding what item numbers have been billed. Puffin's going to do that for you. You know, let's spend more time in patient care than filling out spreadsheets and managing our requirements. A few other things worth pointing out, just because it's interesting, we've included a hospitalisation risk. It runs an algorithm across the patient file, has a look at their risk factors, how many medications they're on and things like that, and it can give you a rating of how likely they are to be admitted to hospital. So you can use that if you want to prioritise patients and you've got a lot. The other really cool thing I want to let people know is we've got this print option. Now, as much as I'm the digital health manager and I would really prefer that you learn how to use Polar, and me and my team can help you with that, to log in and have, because it's all live data, it's all interactable. But what another option is this print function, which we know a lot of practice managers and practice nurses are doing this for GPs, where I can choose to print a full report. It'll take into account the filters. So I'm just looking at Dr. Seuss's patients and I go full report and it's going to give me a printout version as at the current state. It obviously won't keep up to date, but that's that current version. So it's got the dot system so you can see what services they still need. And this full report, it's also got 1 page per patient that has a bit more information about what they have and haven't had, what vaccines they're due for. There's also the option to just print that first page that just has that basic information for that patient's 12-month cycle. So as I mentioned, this is free. Your clinic probably already has Polar, very likely. If it doesn't, we can get it for you. But you've probably already got access to this tool and you're just not aware that it's there, or you need some help using it. We are so happy at Westvic PHN to come and help you use it, to provide some training, some support. There is also this a user guide. There's a really clear user guide. And the last thing I'm going to add is the little catch. There is a catch to Puffin. And the catch is that the patients have to be entered into Puffin. So you might have seen this patient management page. We are very happy to come and sit with your practice manager or a practice nurse. Some GPs may be happy to do it themselves, but you do need to go in and tell Polar who is GPACI registered and when were they registered, so that Puffin knows how to calculate when their 12-month cycle is. It's quite important. Unfortunately, this information isn't in best practice or medical director or ZMed, so Polar has nowhere to pull it from. So it does need to be entered manually, but once it's done, it's done. And we've been teaching practice managers and nurses who are managing this for clinics that when you register someone in Proda for GPACI, you go into Puffin and you add them there too. So it's just that first initial setup that can be a bit frustrating. But once it's set up, it's set up. And I think we've already had some great stories about how this has really helped people maximize their benefit from participating in GPACI. I think I'm time. I'll leave it there.
Thank you so much, Sarah. And now we've got some time for some questions. So I actually put the first one in the chat because I just wanted to ask you, Ash,
About the hourly rate, including the GPACI. Yeah, yes, so that's right. So the hourly rate that I did calculate definitely did include the GPACI fee as well.
Oh, but the practice fee as well. So there's an amount that goes to the GP, and then there's
no. So that one just included the GP's one. It did not include the practice. So that was for a GP individually. Yeah.
Yeah. So they're on top of
so there would be extra for the practice. Yes.
Correct. Okay, great. Thank you for clarifying that.
That's okay.
And
there's a specific question about after hours attendance, and then I just responded to that as well. Around after hours attendance being requested, which is very true for the urgent, but in the non-urgent billing item numbers from an MBS point of view looks different. But as I've said in the comment, very happy to be shown otherwise if anyone feels that's the other way.
Thank you.
Sarah, as someone who doesn't work out of this PHN, can I get Puffin?
Do you know if you have Polar?
Yes, I do.
Then yes, you'll have access to Puffin.
That's exciting. Okay, all right. Oh, okay. Anna's written to me. I think Deb meant the service fee rather than Japaci practice amount. Yes, okay. So no, that was included the 100% of your billing. So obviously that would be separated to your practice with your service fee, whatever that might look like. So no, the answer is purely what the billing amount would have been for the GP, not their own take. Yep. So you would need to separate that again.
Just got one more question. Sorry, Deb.
Yes, Anna.
A way to see which visits in which months. Yes. So if the visit, I might very quickly share my screen again. So, what you can do is when you click on the patient, it comes up with all the services that have been provided. It'll tell you the date, and it will only give you the second green dot if it's been provided in a different calendar month. So you can rely on the dot system, I guess. It's not going to tell you that you're completed if 2 items were delivered in the same month. And thank you. And yes, please complete our evaluation.
Thanks, everyone. Have a good night. Thanks for joining us.